everybody, and welcome back to Mira Anat. Today we are going to discuss a little bit about the abnormality of the heart appearance in the chest X-ray. That means there is a pathology in the heart which is going to be reflected on its shape in the X-ray. Now, like one of the most common abnormality in the heart to be seen in the X-ray is like enlargement of one or more of the cardiac chambers. Okay, so let us see here what we are having. So now here I put for you one X-ray for abnormal heart, and now we are going to detect which chamber exactly is obviously abnormal, whether it is enlarged, smaller than the normal, whatever. And we are going to compare it with the normal appearance of the same chamber in the chest X-ray. Plus, we are going to clarify a little bit about the hemodynamics of this abnormality. So if we compared this to that, we will see here in that normal heart X-ray shadow that there is here, this is, as we mentioned before, this is the convexity or the contour of the right atrium. It is usually, normally, a little bit to the right side of the midline if we want to consider this is the midline of our image. So in the normal heart, usually the right atrium is occupying 1/3 of like one third of the shadow on the right side of the midline, while the remaining of the heart is considerable, like 2/3 of the shadow to the left side. Now, if we have a look to the abnormal X-ray here, we will notice immediately that the shadow for the right atrium is a bit enlarged, and here it is prominent by more convexity of the right border of the heart. So when we find the right border of the heart in the chest X-ray post-anterior view is more convex, this is denoting that the right atrium is enlarged. Now, if we try to see how far the right atrium is shifted from the midline, or like occupying a shadow on the right side of the midline, it is a bit more than 1/3. If you compare it here on that side with that side, this is here, okay, this is here, how much or how far from the midline, and here how far from the midline. So obviously here there is the cardiac shadow on the right side of the midline is bigger than that image. So this is here, there is abnormality, which is, okay, right atrial enlargement. Right atrial enlargement, it might be due to many reasons. If we looked here to try to explain the hemodynamics of this right atrial enlargement, this is here the superior vena cava bringing the blood, and the inferior vena cava bringing the blood, both of them to the right atrium. Okay, so now the role of the right atrium is to push the blood to the right ventricle. So if there is obstruction between the right atrium and right ventricle in the sense of tricuspid stenosis, that means narrow valve, so now the right atrium need to exert a forceful contraction to push the blood across the stenosed valve. So this be one of the reasons to lead to that appearance in the chest X-ray. Okay, one other totally opposite cause, which might be tricuspid incompetence or regurgitation. So in the tricuspid incompetence or regurgitation, what is happening is the blood will pass to the right ventricle, but because the valve is pathologically wide, during ventricular contraction, some of the blood will go to the pulmonary artery and some of the blood will return back to the right atrium. So when the next cardiac cycle comes, there will be another blood coming through the vena cavas, plus the blood that regurgitate from the Breyer cycle. So that's mean volume overload in the right atrium. So right atrial enlargement might be due to volume overload, like that in case of tricuspid regurg, or pressure overload due to valve stenosis. This in case of right atrium enlargement. Now, the following chamber enlargement we need to talk about is the left atrium, since both together are neighbors. So what we can see in the left atrium enlargement? Left atrium usually in the normal cardiac X-ray, it is not appearing because it is located posterior. If we look to that normal anatomy diagram, this is a posterior view of the heart. And here we can see clearly that, okay, this is the superior vena cava, fine. And this is the inferior vena cava producing the blood to the right atrium, and it is making the right border of the heart. But because the left atrium is looking backward, you can't see it if it is normal. It doesn't reflect any shadow on the chest ray. You can see it because it is backward. But in case of its enlargement, it will give us unique appearance, which we call it double density sign. So let us see the double density sign. This is the normal cardiac shadow, normal chest X-ray. Okay. So now, as you see, we can detect in the normal chest X-ray again once more. We can comment that this is right atrium. Its lower part, this part is surely inferior vena cava, while this part is superior vena cava. So they are appearing on the right side. Okay. On the alternative opposite side, we can here denote that this is the left border of the heart made by the left ventricle, and at its conjunction with the diaphragm, this is the left copula of the diaphragm, surely. So now you see the angle between the heart and the diaphragm is obtuse angle normally. If we went slightly upward, we can see a slight a bit knuckle, aortic knuckle, then followed by pulmonary shadow, pulmonary artery shadow. As you see here, we can see anything for the left atrium. Now, what is happening is, in case of left atrial enlargement, we will see something called double density sign. What is double density sign? You can see the regular contour of the right atrium, which is convex, and here the convexity is much. That's mean, I believe it is also, there is also right atrial enlargement, plus some other shadow, again, which is more to the right side, which is the left atrium. So this is, they call it double density side. So here, I'm not telling that the right atrium is surely normal, because it isn't as it seems. If we try to compare it to the midline, how far it is from the midline, this is actually more than this one. The distance between the midline and the contour of the right atrium on each side, if we try to compare it, it is definitely more. So here there is right atrial enlargement, definitely, but here I'm not commenting on the right atrium. I want to comment on the left one. Okay, so when you see as if the right atrial border doubled, this is what they call it double density sign, which is denoting left atrial enlargement. Okay, why have left atrium all of a sudden showed to the right side? We told that normally it is backward. Okay, so to understand this, let us see here the heart from its backside. The heart from its backside, this is a right border of the heart made by the right atrium, which is normal. Okay, which is that one. I'll make it like that in the same color. Fine. When the left atrium enlarged, okay, this chamber, which is the left atrium, I'll make it with another color. This is will enlarge in such a way it will start enlarging and encroaching backside to the right atrium, so it is appearing on the right side of the right atrium. So this is when the chamber enlarged. Okay, it is not only pushing the right atrium, sometimes if the enlargement is bit a lot. Now you can see here that the border of the left atrium is to the right side of the right border of the heart, which is literally the right atrium. So this is left atrial enlargement and how it is happening. Now one might ask, what makes the left atrium enlarged? The same way and the same mechanism as the right atrium, meaning this here is the left atrium. And this is the mitral valve, this is the left ventricle. So the left atrium, its function to push the blood through the mitral valve to the left ventricle. Now, if the mitral valve is narrow, That means the left atrium need to contract against the high pressure, which is called pressure overload. So with time, the wall of the atrium will be thickened and it will give me overall enlarged shadow in the X-ray. So the first reason for left atrial enlargement is mitral stenosis. On the other hand, as we mentioned before, it might be mitral regurg. In such a way, after the blood will go through the mitral valve, which is open abnormally, wide, more wide. Okay, so after the ventricle will just pump it to the aorta, some of which will return back again through the wide valve abnormally to the left atrium. When the following cardiac cycle comes, some blood will come from pulmonary veins to the left atrium plus the regurgitated blood from the prior cycle. So this is called volume overload. So usually in atria, put it in mind, when there is atrial enlargement, whether one atrium or both atria, usually put in mind it is either due to pressure overload, that means they are pushing against very tight valve, or volume overload because they are pushing against wide valve, which is making regurg when the blood is pushed or pumped to the blood vessels. So this is regarding the left atrial enlargement. One thing denoting also the left atrial enlargement, you will see that the carina is the angle between both bronchi is obtuse. Okay, I'll try to make this up to see and make you see instead of my scribbling here over the image. What do I mean by carina angle? Okay, now let us look. Okay, let us look to the trachea and its bronchi. If you notice here with me, you will find out that this is the shadow of trachea. It is translucent a bit, that means it is little bit dark gray. And here there is a division or the bifurcation into two bronchi, right and left. Usually the angle between the bronchus and the other one is right angle or less. In case of left atrium enlargement, you will find that this angle converted from being right to obtuse, as here. Here we said there is double sign, double density sign, right? That means left atrial enlargement. Now, here it is clearly that this is a trachea, as you see, and at its carina, when it is divided into the left bronchus and the right bronchus, this is the left, this is the right. If you see here the angle, it is not definitely right or acute, it's obtuse. So this is another indicator, this is another confirmatory sign that you can pick up from the X-ray to make you sure that whatever you are seeing as double density sign or double border sign is atrial enlargement. So now we discussed both atria, right and left. Let us move to the ventricles. Okay, I'll start with the left ventricle. The left ventricle normally is making obtuse angle, as we discussed before, with the left copula of the diaphragm. This is normal. So what it will look like when the left ventricle is enlarged? When the left ventricle is enlarged, first thing is you will find a downward shift of the apex in the X-ray. Instead of being in the fifth left intercostal space, you will find it shifted. It might be to the 6th, to the 7th, to the 8th, to the 9th, according to the level of enlargement. Okay, so let us first try to, here in that image, count the ribs and see our apex in which level. So now if I wanted to count the ribs in that photo, so this is our clavicle as we knew before. This is first rib, and here again I remind you we are counting the anterior ends of the ribs in a postero-anterior view, chest X-ray. Usually if you want to trace these ribs, you have to start from the periphery, then you move the shadow of the rib downward, forward and inferior. So this here is the first rib, second rib, third rib, fourth rib, fifth rib, sixth rib. Okay, you might see that as if the heart is obscuring the ribs, you can't trace it anymore, but from the periphery here you can see this is the following rib, and this is the following rib, and this is the following rib. So now if we try to count, this is first space, second space, third space, fourth space, fifth space, sixth space, seventh space, eighth space. So our apex in the eighth space. And now if you look to the angle between the little bit copula of the diaphragm here and our apex, you will find it more or less obtuse. Okay, so here this is the angle. So obtuse angle denoting that there is the apex is made by the left ventricle, or there is a left ventricular dominance, which is normal. Like normal, the apex is made by the left ventricle, but the push down of the left ventricle beyond the fifth intercostal left space, that means there is left ventricular enlargement. Left ventricular enlargement happens simply in most of the cases, and this is very common cause that the patient come to your clinic by, is hypertension. Increase the pressure in the blood vessel, so the left ventricle is pushing against high blood pressure. So now to see the hemodynamics here in that cardiac diagram or heart diagram, diagrammatic anat. So this is our left ventricle, and this left ventricle should push his blood here through the the aortic valve. So this is the aortic valve. So now I'm having what we call it pressure overload. This means the ventricle is pushing against the pressure overload. The pressure overload here, it might be stenotic valve. That means aortic stenosis might be there, whether it is congenital or rheumatic, due to rheumatic fever, or a part of Turner syndrome. So now when the ventricle is pushing the blood against the closed or narrowed valve, with time this muscle will get hypertrophied, as if you are playing exercise or carrying weight in the gym. With time you will find your muscles are getting enlarged. So this will lead to increase or widening of the shadow of the left ventricle in the chest x-ray. Will give you left ventricular enlargement in the chest x-ray. So first is pressure overload due to aortic valve stenosis. The second thing, it might be is a problem not in the aortic valve, it might be in the arteries itself. As I told, high blood pressure due to atherosclerosis. So atherosclerosis will make plaques in the blood vessel wall and make the wall with time narrowed. Like the wall will be thick and the lumen will be narrowed. So again the ventricle is pushing against narrow blood vessels, so it will be enlarged. So whether it is hypertension, whether it is aortic stenosis, it might be not this one and that one. It might be third reason, like what? Like for example, aortic regurg. So in case of aortic regurg, what will happen here? After the ventricle is pushing the blood through abnormal aortic valve, he will push the blood like that. Part of the blood, because the valve is wide, will return back to the ventricle. So now after ventricular systole, there is blood returning back little bit to the left ventricle. When the following cardiac cycle comes and the left atrium trying to pump blood to the left ventricle, now you will have the volume coming from the left atrium plus the regurgitated blood from the Brier cycle. So this is considered as volume overload. I am having extra volume that the ventricle should accommodate. So again, this will lead to left ventricular enlargement. So in case of mitral regurg, aortic stenosis, or systemic hypertension, this might happen. The left ventricular enlargement not only will lead to push down of the cardiac apex below the fifth left intercostal space, but sometimes, as this X-rays that we are viewing is making the border of the left border of the heart, which is made by the left ventricle, is slightly bit convex. And this is with the dilated aorta sometimes, or prominent aortic knuckle sometimes. it gives us this sign that you are seeing, Schmoo sign. Schmoo sign, this is a character, cartonic character. Okay, so this is the left ventricular enlargement and the hemodynamics beyond it, why it might happen and how it might happen. The last cardiac enlargement as discrete chambers, I'm talking now, as you see, I started from the right atrium, then the left atrium, then the left ventricle. Now I'm moving to the right ventricle. The right ventricle, it might be enlarged due to many reasons. It might be due to whether pressure overload. Pressure overload, this means the right ventricle again is pushing against stenotic valve. So pulmonary stenosis, whether congenital, isolated congenital pulmonary stenosis, or even unfortunately due rheumatic fever, it might cause the right ventricular enlargement. So now, usually what is happening in the normal situation, the right ventricle is pushing the blood through the pulmonary valve to the pulmonary artery, and it should be smooth process, no problem in it. But now, if the valve is tight or stenosed, every time the ventricle is pushing the blood or pumping the blood, it has to exert a lot of effort, a lot of muscle contraction to be able to push against that blocked valve. So this is one of the reasons or one of the hemodynamic mechanisms that might lead to right ventricular enlargement. What else might lead to right ventricular enlargement? If I draw here, scribble a little bit diagram about the heart, which is a very simple diagram, it has nothing to do with the normal view of our real heart. So here, this is the interventricular septum. This is the pulmonary, this is the mitral, the tricuspid valve. This is the mitral valve. This is the interatrial septa. This is the interventricular septum. And here we can I can quickly draw, okay, for the sake of ease. Okay, so here I'm going to draw the aortic artery, okay, and the other side I'll draw the pulmonary artery. So here, this is pulmonary artery, this is right ventricle, this is left ventricle, right atrium, left atrium. Okay, so we discussed over here the stenotic valve, stenotic pulmonary valve, whether it is isolated or it might be part of phallotetralogy, which I'm coming to it now. Okay, before I discuss the phallotetralogy, there is some sort of volume overload that makes the right ventricle enlarged. What do you mean volume overload? After birth, normally there is no foramina or no holes connecting the atria together or the ventricle together. And if there is such a connection, it will be called, if it is between atria, it is called ASD, atrial septal defect. If it is between ventricles, it will be called VSD, ventricular septal defect. Normally, after birth, the left-sided chambers having higher pressure than the right-sided chambers. In such a way, for example, you can know that the left atrium has, okay, pressure about 5, while the right atrium 3, okay, the left ventricle is 90, while the right one is 25. So normally the difference in pressure, and this is normal difference in pressure between the chambers, right side and left side. So normally the blood flow tended to go from the high pressure to the low pressure. So if I am having a baby with an SD, congenital ASD, so the blood will tend to pass from left atrium to the right atrium. Is it a problem? It is not that much a problem because the blood that is moving is oxygenating blood, so it will not make any cyanosis or it will not make any big deal for the baby. But the problem is this right atrium is already having blood from both vena cava. So now I am having blood coming from the superior and inferior vena cava plus the blood jumping from the left atrium. So now I am having volume overload to the right atrium. This volume overload to the right atrium will pass. So now we will have two arrows, blue from the two vena cava plus the red one coming from the left atrium will be here. So now the right ventricle will have also volume overload. So with time If this is not corrected, the right ventricle will be enlarged in the form of dilatation. So this is in case of ASD. Now, what if it is not ASD, not atrial septal defect? It is otherwise. What is otherwise? Otherwise is ventricular septal defect. So normally, instead of that much blood coming from the right atrium to the right ventricle through the tricuspid valve, this amount of blood, no matter what, 10 milliliter, for example. Now, because the pressure in the left ventricle is higher than the right, and if there is VSD, ventricular septal defect, some blood will pass by during ventricular systole here again to the ventricle. So again, we have volume overload. So now I discussed with you whether it is pressure overload due to stenotic pulmonary valve, or it might be volume overload due to septal defect, whether it is atrial septal defect or ventricular septal defect. This pulmonary stenosis that I discussed, it might be a part from or a part of a very well-known syndrome, which is Fallot tetralogy. Fallot tetralogy, that means we have 4 features here in the newborn baby, which one of them is pulmonary valve stenosis that with time will make this ventricle suffer. As you see here, the thickness of the wall with the time it is getting thick because it has to push against obstructed or stenosed valve. So pulmonary stenosis with time will lead to right ventricular hypertrophy. This Fallot of tetralogy usually having extra 2 features. One of them is volume overload, as I discussed here, which is ventricular septal defect. And the 4th one is what we call it overriding of aorta. Overriding of aorta means simply that I am having the right ventricle and the left ventricle. Usually the aorta should only take the blood from the left ventricle. The word overriding means that the aorta is here in a position in such a way it can take the pumped blood from the right ventricle and the pumped blood from the left ventricle. So what is the problem in that case? In that case, usually the blood tends to go the easiest way. What do you mean the easiest way? If I am having the aortic valve is normal and its width is appropriate, and on the other side I'm having pulmonary valve is stenotic. So which pathway would be preferable by the blood? The blood will tend to pass through the easiest way, through the aorta, instead of passing through the pulmonary. And because of that, because that overriding, and because the aortic valve is normal compared to the pulmonary, the blood in Fallot tetralogy tended to jump or pass from the right ventricle to the aorta. This blood is non-oxygenated blood, and its passage to the aorta will lead to the cyanosis in Fallot tetralogy. So this is the way it is in Fallot. So this is to explain to you that in Fallot there will be right ventricular enlargement or hypertrophy. Let us move to how it looks like in the X-ray. And chest X-ray of Fallot is unique, and it is, you can look at it and diagnose it just like from the first side. And it is looking like a boot-shaped heart, or it called sometimes a Corin Sabot in French. Okay, so now what is happening in that Corin Sabot or boot-shaped heart? The boot-shaped heart means that we have the narrow blood vessels, narrow areas that contain blood vessels. So instead of having here aortic knuckle and then pulmonary artery, we don't have anymore. So you will find instead the blood vessel part that we should have 2 projections or 2 bulges. It is giving you concave border. It doesn't show you the small tiny projection that denotes the presence of aortic knuckle and pulmonary artery. Why it is? Because, at least for the pulmonary artery, because the stenotic valve make the blood prefer to go through the aorta instead of pulmonary. So for that, the pulmonary shadow for the pulmonary artery, it is not prominent because there is no much blood passing through that artery. So this is the narrow part of the boot-shaped heart. Okay, what about the Corin Sabot or like the remaining part of the boot? If you look at it, you will find that the apex is not resting like that as on the diaphragm making obtuse angle. It is not like that. So it is like what? When the right ventricle enlarged, it will push the left ventricle more lateral. When the left ventricle is pushed more lateral by enlarged right ventricle, it will be like that. So you will find more or less the angle converted into acute angle, not obtuse angle. So now let us see here the cardiophrenic angle on the left side, which is between the left copula of the diaphragm and the heart. As you see, it is acute angle. So always when you see acute angle in the chest x-ray, if you are commenting on the heart, you expect right ventricular hypertrophy, which might be due to ASD only, VSD only, or any valve disease, pulmonary stenosis, isolated congenital, or it might be a Fallot tetralogy. Okay, so first of all, the acute angle, which is called left cardiophrenic angle, is acute. Why? Because the right ventricle, enlarged right ventricle, is pushing the left ventricle more lateral, so the left ventricle relationship with the diaphragm got changed now. And also it makes the left ventricle look like as if it is upward looking toe. Okay, if you return back to the normal view of chest x-ray, you will find usually the left ventricle should descend smoothly and make a relationship with the diaphragm like that. Smoothly, sloping downward smoothly, without being pushed lateral like that. So the appearance in Fallot tetralogy especially is both heart shape or core in support. The last thing I need to comment about is the generalized cardiomegaly. Generalized doesn't mean more than one chamber. It might be 2, it might be 3, it might be the whole 4. It might be fluid around the heart like this case, which is pericardial effusion. So now let us quickly look to the normal cardiothoracic ratio. This is a normal X-ray as you see it. So what you can see in the normal X-ray, the cardiothoracic ratio means the distance between the two faraway points of the heart transversely, the farthest point in the heart in the transverse diameter. This and this, you measure it and you compare it to the farthest points of the thoracic cage, the widest point between the ribs, which is this and this. Okay, this heart shadow shouldn't exceed 50% of that all transverse thoracic shadow. It might be 50% or less. When you find it more than 50%, even though it was 55, that's mean little bit a stage of cardiomegaly. In that case that I showed you here, or I'm showing you here, it is not 53 or 55%, it is exceeding than this. It might reach to 80%. So now I am seeing a chest x-ray with the heart shadow, the distance between the widest point of the transverse diameter of the heart is all that much, while the widest point in the thoracic cage in the image I am seeing that much. So it is definitely exceeding even 80%. So this is definitely cardiomegaly. So usually this big, huge cardiomegaly, it can't be due to one chamber enlargement. Usually it has to be due to more than one chamber enlargement. Or in otherwise, fluid around the heart, which is called pericardial effusion. Pericardial effusion, it might be due to any reason. It might be due to viral infection. It might be due to cancer metastasis. It might be due to autoimmune reaction. Like it might be due to many reasons. This is not the case now. But the case is, first of all, it is giving you cardiothoracic ratio more than 0.5. Okay, or more than 50%. The second thing, the heart is broadest downside, is very broad down and very narrow up, which is giving you the bottle sign appearance. So the bottle sign appearance, as you see here, the wide heart down while it is narrow above, this is usually due to pericardial effusion, which it might be transudate, exudate, blood, lymph. It might be due to many things. So now we covered together the causes or the abnormal features that you might see in chest x-ray due to enlarged heart, whether enlarged heart, discrete enlarged chamber, like discrete one chamber, left, right, ventricle, atria, whatever, or it might be the whole heart is enlarged like pericardial effusion. I hope that you get benefited from that session. If you like this session, please like and share with your colleague. Let us spread the information. Thank you very much.